Oh, no worries. I've worked here 22 years. I know it felt like longer. That's for sure. But it was, yeah, it was an exciting time. Oh, is that okay? Yes, you look familiar, but. Okay. Yeah, they tend not to give them to advocacy groups. They tend not to give you grants.
So I would encourage people to move up. There's no extra charge for seats in the front, if you'd like.
And it's not church.
And it's not church, as Sue points out. So let's get started here. Sue is a very busy advocate for decades. And so not surprisingly, she has places to go and things to do after this. So the invitation to Sue was precipitated by our Justice Seekers Committee and the interest in that committee in having some information start to come to us more formally as it relates to mental health issues, in particular for ourselves as an aging population, and also as a result of the presentation we had from Vale Place. Some of you, or maybe many of you, were at that presentation where we learned about the good work that Vale Place does and some of the challenges they have in getting funding, stable funding, long-term stable funding. And so Sue has information on both of those topics. So I'm going to let you introduce yourself. As there's a couple people in the room, in addition to myself, who have known Sue in her advocacy role for nearly 40 years or more. So she is as they say, a tireless advocate for people with mental illness. Prior to that, people with developmental disabilities, where she and I crossed paths. And so she's a wonderful resource. Organization's a wonderful resource, and we look forward to hearing from you. Thank you.
Thanks so much, Jim. So first, what I'm going to do is actually talk about this last legislative session, because people think nothing happened. And actually a lot did. Okay, now, of course, it worked before. There we go. So we actually had huge gains during the last session, over 90 million in new funding, which of course I think it should have been double that, but you know, you make progress sometimes a little bit slowly. So one thing that happened, is actually in the paper today, there was a court hearing, is the 48-hour law task force. So about a decade ago, the sheriff said, you know, we don't like these people with mental illness being in our jails. And once they're deemed incompetent to stand trial, then they go through commitment. And then as soon as they're committed, they're supposed to go to, usually it's Anoka Regional Treatment Center, within 48 hours. Well, of course, the state hasn't been able to meet that lately because we don't have open beds. So not magically going to move people. And as I always tell the sheriffs when they complain to me about all the people with mental illness in the jails, I ask them, so how did they get there? Who brought them there? You had alternatives, right? And one of the counties that's suing, actually, the person who has been sitting in their jail now waiting for a bed at Anoka for over 4 months was arrested from the emergency room where he was seeking mental health care. So then I'm kind of like, well, that's on you, honestly. So now there's a task force to say, what can we do? Because the only way you can get into Anoka right now is from the jail. If you're in a regular hospital, you can't get there. And that's also not right. So there's a group that's meeting now. Farmers' mental health, which is an issue because if we look at the suicide rate, it's older men in rural Minnesota. And so we want to make sure that they connect to mental health services. Cannabis, as you know, all became legal. We weren't really happy about that. We wanted to decriminalize it, but making it legal is problematic because on that developing brain, before the age of 26, cannabis can actually lead to psychosis. And we've seen higher numbers of people with psychosis in states that have legalized it. So we did weigh in on some of the bill, a lot of the bill, but one of the big things is we managed to get the warning label to be up to age 26. So at least if a 21-year-old, not that they're going to read the label, but we're hoping, it'll be like, be cautious, right? We were not able to get a warning label for pregnant people. I'm kind of like, a drop of alcohol is not okay, but gummies are, but they're going to do a study. So we managed to do that. We also managed to make sure that any program that is licensed by the Department of Health or Department of Human Services can say we can't have those products on our campus, which also makes sense because like using in a substance use disorder facility doesn't make sense, or a mental health facility. So we managed to get that in there too, which I thought was also important. And then the money that's going to be raised from the taxes, a part of it has to go to more culturally specific mental health programs and SUD programs, but also for first psychotic episode programs, so that as we get these young people who are, developing psychosis because they're using cannabis, we can have more programs to actually meet their needs. Children's mental health was a big thing because, as we all know, our kids are really, really struggling. So the first thing is banning conversion therapy. Conversion therapy is really horrible to young people. You just can't do that. You're not going to pray it away, and so banning it really made an important statement to those young people. Some other things like, we have kids that have been boarding in the emergency room, right? And what's happened is that the hospitals have actually referred those parents to child protection for neglect. And we said, no, those parents aren't neglecting their kids. The system is neglecting the kids. And so now the hospitals will all get kind of a memo, if you will, from the Department of Human Services saying, please don't refer those kids, those families to child protection. And it's not like there's nowhere for these kids to go. So referring them to child protection as if they have a magic wand to magically have a kid have a place to go is also ridiculous, right? So we managed to get that in there too. For many years, we have grouped together children's residential, mental health residential programs with child protection. So, 30 years ago, if you wanted your kid to go into residential treatment, right, and you didn't have money to pay for it out of pocket, you basically had to relinquish custody of your children. So that changed in Minnesota that said, well, you don't have to relinquish custody. And then we made it, but you still had to go to court. Then we made it so it would be a voluntary kind of arrangement so that you would still keep custody of your child, but essentially the county is still overseeing that placement. And then the Family First Law passed on the federal level just a few years ago, which actually hurt our voluntary piece because no matter how the kid is getting into out-of-home placement, if you're using what they call Title IV-E funds for room and board, you have to do a relative search. And our families were like, this isn't a sleepover. Why are you going to just reach out to any of my relatives? This kid needs intensive residential treatment. And plus we had some families say, my kid is transitioning and you're going to invite my homophobic uncle to the table to help decide what happens to my kid. I need to have a right about who's at the table. So what we did is we actually got state money to pay for room and board. So now we've bypassed all of that. And never should we have put, frankly, kids' mental health in with child protection because they're not related. This is about a kid's mental illness. We also wanted to make sure that crisis services, so in Minnesota, all 87 counties are covered by mobile mental health crisis teams. We wanted to make sure they also had training on children and families because they tended to work more with adults. So we wanted them to understand that. Now, some people have said, and we've seen this, that some cities are now creating their own crisis teams, which is creating a mess because we're trying to create a unified mental health crisis system. Again, all 87 counties are covered. And we've had some police departments say, well, they can't come out quick enough. The entire budget for our crisis services in Minnesota is less than the city of Rochester's police department. So you cannot expect them to respond in the same way, right? But if they really wanted that, additional service, they could contract with the crisis team instead of hiring their own. Because when they hire their own and that social worker is actually an employee of the city, guess what? HIPAA doesn't apply. We don't want that kind of information out there, right? Just on someone's desk or in an Excel spreadsheet. Some other things that we did is we made Minnesota a safe space, right? For families coming from other places where they're being charged with child protection because their kids are looking at transitioning. So if they're being charged with child abuse or child neglect in another state and they come here, our state won't send them back. So they'll be protected here, which is also a good thing. For many years, we've had these facilities called psychiatric residential treatment facilities, which are a step down from the hospital and a step up from our typical children's residential facilities. And we started off with it being a Medicaid benefit. All the private insurers said, it's a Medicaid benefit. We don't have to cover that. And we're like, well, under state law, you're mandated to cover residential and hospital. You pick. They're like, no, it's a Medicaid benefit. We couldn't get them to cover it. Even though kids were boarding in the emergency room who needed that level of care, they would not cover it, which I thought was unconscionable. I also thought it was a violation of mental health parity laws, but we couldn't win. So we mandated it. So now they have to cover it. I'm like, haha. And we put some startup money in there because we couldn't get new places to develop because if they only relied on Medicaid, they couldn't financially do it. So this will also help develop more beds so we can meet the needs of kids. School-linked mental health, which is one of my favorite programs, did get more money, but oddly less in the second fiscal year, which you can't really do. You can't all of a sudden like fire all these clinical social workers. But basically what school-linked is it's money that actually goes to community mental health providers who co-locate in the school. So we eliminate barriers to access for families. Because I can tell you, if your kid has depression and you're going to bring them to therapy visits once a week for 22 weeks, your employer is not going to let you do that. You are not going to be able to use your sick time for that. And so what we saw is that kids weren't finishing their treatment plans because the families couldn't do it. Think about rural Minnesota, right? You're driving 45 minutes to pick up your kid, an hour to the therapist, back, right? I mean, it's just a mess. So now we eliminate all those barriers. And the grant money is used for kids who are underinsured or uninsured, and for things that you can't pay for, like collaborating with the teacher. It is a wonderful, wonderful program. And there is, frankly, a firewall between the mental health records and the school records, which is also important. Right now, this program is in about 60% of actual school buildings in Minnesota, and everybody loves it. But we need to be in all the buildings, especially because of the kids' crisis that we're in. And usually by November, they have waiting lists. I mean, that's how popular this program is. And then transition to community, which is what we used to call whatever it takes to help adults get out of the hospital, was expanded to kids, but they didn't put any money there. So I'm like, well, that's nice. On the corrections side, there were a couple of cool things. One is creating a family support unit within the Department of Corrections. We know people go into prison and have families. And we also know that they do better when they're released if they stay connected to those families. So now we'll have somewhat of a focus on that, which I think will be helpful. Free phone calls from the prisons, also important to stay connected to people, right, and your family. There's some money for jail discharge planning. They're looking at a mental health unit pilot program. So in, I'm going to forget the name of the prison. In one of the prisons, they have kind of the high level mental health unit, and they're not using all the beds. So they also are looking at, could we move some of the people from the jail who are very, very sick into that unit so at least they could get treatment? And then this was one of our bills. We wanted free phone calls from the jail if it's related to mental health, because this is now a county issue. So we didn't, we couldn't put too much money on the county, but we wanted to say if someone goes to jail and they want to call their case manager, it should be free. If they go to jail and they're feeling suicidal and they want to call the warm line or 988, that should be free, right? If they want to call their therapist, that should be free. We want to have them stay connected. So that did pass, which I thought was good. Early childhood, just a couple things I'm going to talk about. We're finally going to get a mental health services lead within the Department of Education. And it's not in special ed and it's not in safe schools. It's by itself. And that really is important. I can't tell you the number of schools when there's a suicide attempt or a child has actually completed suicide, they don't know what to do and they do all the wrong things. And then we have contagion, and then we see other kids in the school die by suicide. So we want there to be a point person within the department that can really help schools through that. Or if they don't have one of those schooling grants, right, what can they do in the meantime to make sure that kids can access services? Naloxone is going to be in all the schools, which also is important. Our paraprofessionals will get some training finally so that they can actually really work well with the kids that they're with. Restrictive procedures, which is something that I've worked on my entire life to try to reduce the use of. Now you can't use it for kids in K-3 starting next year. Now, there's a debate, right, on this issue, and it's kind of different between, frankly, the developmental disability community and the mental health community. In the developmental disability community, seclusion restraints were used basically for behavior modification. And they certainly was true back in the 80s, right? But for the mental health side, it was used in emergency, right? To protect a child from hurting themselves or others. So you have these two kind of communities coming together with disagreements on how to proceed. Because what happens if we take all of these things away is that kids then get sent on homebound. And that's not good for the parents, right? Or in a more restrictive setting. And so we need to make sure that we balance this out so it's only used in emergencies. And the kids that they use it the most on is about like age 9 and 10. And if you think about it, that's when kids start to get big, but boy, their brain is way behind in terms of being able to regulate their emotions. Another thing is not taking away recess as a punishment. I had a brother who had ADHD, and what my mother used to do, and we went to Catholic school, so what my mother used to do was give him a bunch of coffee, make him run around the gym, and then go to the classroom. And so, taking away recess when kids are already feeling, a little antsy is kind of counterproductive, right? You want them to move around. It releases endorphins in the brain. It helps them calm down. I mean, it's just a good thing. Another thing is not allowing suspensions for kids in K-3. I mean, we were suspending a ton of kindergartners. And right now, because especially after COVID, suspending them doesn't teach them anything, right? We want to teach them social emotional skills. And what we know is that kids who get suspended a lot by the end of grade 3 typically don't graduate from high school because they've disconnected to the school. School isn't a safe place. School is no longer a welcoming place. They're no longer engaged. So it's kind of counterproductive to do that. We need to teach them the skills, right, to do well in the classroom. The other thing that was really cool is requiring all the student IDs to have 988, which is the new suicide and crisis lifeline, because no one could ever remember 10 digits. So it's around the country, it's 988, which is great. And all the crisis lines for the local crisis teams in their community, which also will be great. So employment it's been a problem for people with mental illness forever. They have the highest unemployment rate. And yet DEED doesn't do much at all when it comes to this. I have actually tried to meet with the commissioner of DEED for 21 years. Last spring, I finally got an appointment, and a week later, he was announced to be the new publisher of the Star Tribune. I was like, seriously, could you have waited a few more weeks? But the problem is that most employers have no idea what an accommodation is for a mental illness. If someone shows up in a wheelchair, they know exactly what to do. If someone shows up with schizophrenia, bipolar disorder, depression, they have absolutely no idea. And there's tons of low-cost things. And then those individuals also don't know how should I apply? How do I explain my, break in employment and things like that? So we have one program that's evidence-based called Individual Placement and Supports. but we also want to do more with Indeed because work is actually a evidence-based practice to help people get better. You have to have a reason to get up in the morning, right? And living on SSI is not easy. And so then you put money in your pocket, which is also a nice thing. And then you're not lonely because you're connecting with other people. So it's a really important program that we don't fund enough. Now, extreme protection orders were also passed this year, and that was basically, they call them the red flag laws, so that you can remove the guns from people who are a danger and originally to themselves and to others. We got the language to be changed. Instead of a danger to yourself, we said who is suicidal. Let's just say it, say the word, make it easy. It's not any other kind of danger. It's only when someone is suicidal that we want to do that. And because of that, we also said that those orders are private. Nobody needs to know that someone was suicidal, right? The community doesn't need to know that. If they're a danger to other people, yep, we understand that, but not if they're just suicidal themselves. So those records will be private so their neighbors won't find out and things like that, which is also really important, especially in rural Minnesota. A couple things on the healthcare side, allowing foster youth to stay on Medicaid until age 26. So other kids get to stay on their parents' insurance until they're 26, right? But what if you've aged out of foster care? You don't have parents, right, who are supporting you. And so those kids were really just kind of dropped off, frankly, in some ways. So now they can stay on Medicaid, which is also important so that they can get, mental health care and things like that. Telephonic care is expanded for another 2 years. And actually, it's the mental health system that used telehealth and telephonic care the most. And it really has helped. We've had fewer no-show appointments, right? Because if your medication makes it hard for you to get up and you're going to miss the bus, well, you just flick your phone on, right? It's easy. And you connect. And for a lot of people in rural Minnesota in particular, this was really helpful. And not everyone has a smartphone or a computer or anything like that. And so being able to connect even by phone was also really important during COVID. And we actually wanted to continue it because people found it really helpful. Tobacco cessation is also an important thing. People with mental illnesses smoke the most and consume the most tobacco on top of it. And it actually prevents some of the medications from absorbing into their system, so they actually have to take more. And usually what they did before this, before they expanded it, is they said you could only try to quit once a year. Well, anyone who ever tried to quit knows it takes more than once, right? And then they said, well, you can only use one of the things. But because people with mental illness smoke so much more, they needed multiple products, right, to really help them quit. So this is expanded now. And then if anyone's ever tried to get a therapist, especially in the last couple of years, you're looking at 3 to 6 month wait easy. But we also know that health plans have very narrow networks. And so sometimes we call them phantom networks. And you can watch for an article out of the Minnesota Reformer in the next couple of days just to show you how phantom those networks are. And so, the health plan will say, well, we have these 10 therapists, and you call them and none of them are taking new patients. But the state says they've met network adequacy because they have therapists within 30 miles, 30 minutes. Well, that's not a network, right? You can't access care. So what we said is that, first of all, for the next 2 years, health plans have to take in any willing provider so that they can expand those networks. And then the other thing we did is we said 30 miles, 30 minutes means nothing. You need to look at wait times. You need to look at how many psychiatrists, for example, per population. So we need to do it that way instead of just looking at the miles and minutes. Housing, as you know, is a really huge issue. It's why a lot of people end up in jail. We know that a lot of people with serious mental illness are homeless. So there were a couple things that happened. One is Bridges Rental Assistance, which is basically Section 8 for people with serious mental illnesses. And so that money was expanded, which will certainly be helpful. Also housing with supports. So some people need those long-term supports. They don't need an institution, but they need those long-term supports. And then also making sure we had a landlord risk mitigation project. So there are some people that it's just hard to rent to. They have a terrible rent history, right? Maybe they did some damage, maybe they have a criminal background, all those kinds of things. So what the risk mitigation does is it tells the landlord, listen, we'll make you whole. So if that person skips town and doesn't pay rent, if they put a hole in the wall, we'll fix it with this money. It won't be on you. And so that makes it a little easier for landlords to actually rent to people who maybe don't have a good housing history. And then termination of lease for residential treatment. We had people going into residential treatment, which is typically for 90 days, sometimes longer, and they couldn't break their lease. But they also couldn't afford to pay for their housing while they're in residential treatment. And so this will allow them to actually break the lease, which will also be helpful. Couple of things in human services. As you can see, I'm not reading through everything, but a big thing is general assistance. They finally increased the amount from $210, I think it was, to $350. Woo. But you know, it helps, right? Because I feel so sorry for those people living on that little money. But it helps to get that. And now it's going to be tied to cost of living increases, which also is a good idea. And then some rates, of course, were increased for some of our human services. Our life insurance policy in Minnesota basically said that if you took your life within 2 years of that life insurance plan going into effect, the family got nothing except the premium sent back to them. Now, if we know anything about suicide is people don't plan that out like that. They just don't. Most suicides between the time someone decides to take their life and actually tries is 5 minutes. So no one's thinking about, oh, I'm going to get a life insurance plan, then I'm going to wait 2 years, and then I'm going to take my life so my family can get the money. It just doesn't work that way. We got it down to 1 year. We're going to come back and try to get it lower, but at least it's down to 1 year, because that was really, it was just so hard for families who lost someone to suicide and then didn't have the money that was really there to protect them, right? And we had a wonderful dad who came and spoke. His 2 little kids, his wife took her own life during postpartum depression 3 weeks before the 2-year policy. So, and they got nothing. Mental health care. So 988 is now funded with a telecom fee, just like we do for 911. Now 988 is not exactly like 911, but it is a crisis line. Anyone can call in, including if you're concerned about someone else, and they can send out our mobile crisis teams, which is also really helpful. But it was, you know, it wasn't funded very well. So now we have a telecom fee so that we'll have steady money going to keep building that up. One issue that I've been working on for a long time is if you're on MFIP, Minnesota's welfare plan, but your children are on it, you aren't, because you have a disability, so you're on Social Security, you don't qualify for childcare, which makes sense because you're not required to work because you have a disability. But what if you have a mental illness? And what if you need treatment? Or what if you're not doing well? Now, on the advice of a mental health professional, they'll get 20 hours of childcare. So if they need to be in day treatment, they have a safe place for their kid to go. If they're not doing well, we're going to have an adult be able to respond consistently to that child, which is really important in terms of child development. We have a new thing called collaborative care that will be required under private insurance to fund. The CMIG grants are the Cultural Ethnic Minority Infrastructure Grants. They used to get about $600,000 a year through the federal block grant. They're now going to get $3 million a year. And that's really to build up our culturally diverse mental health providers. In Minnesota, about 90% of our therapists are white. That's not reflecting the rest of our state, right? And so that's an issue. Direct care and treatment, basically state-run services, are going to be their own agency. This kind of starts kicking it off. We've wanted this for years because we think it's a conflict of interest for the Department of Human Services to run services, to license those same services, and to fund those same services. Yeah, it doesn't really work, right? And so separating it out is a good thing. So that will happen over time. And then the first episode of psychosis programs got a little bit more money too. And if you don't know what those are, basically the way we've treated schizophrenia in the past is we won't do anything until you hit stage 4. That's pretty much what we do. And schizophrenia is one of the most disabling conditions in the world. And so to do nothing until someone has basically been hospitalized numerous times or ended up in the criminal justice system is horrible. But there is an evidence-based program called First Psychotic Episode Programs. It's actually done around the world, Australia, France, Norway, all sorts of places. And in Minnesota, we have 4 programs. What they do is they try to get that young person early. So right now, young people wait about an average of 74 weeks before seeking treatment. Remember, they're hearing voices. They're seeing things that aren't there. It's pretty serious symptoms. So they try to get them in earlier. And then they kind of hit them with everything, right? So they're going to do therapy. You're going to do low levels of medication because you're catching it early. You're going to educate them about the illness. You're going to do cognitive remediation. You're going to do family education and support. And you're going to have someone on that team that helps that young person get back to school or work so the trajectory of their life doesn't change much. That's amazing. We actually provide the family peer specialist on 3 of those teams. And, she has gone to graduation parties for kids graduating from the U of M, people getting back to work. I mean, does it work for everyone? No. Does it work for a large part? Yes. And the public health side of me says, we can't do really primary prevention in terms of schizophrenia other than not using cannabis for some people. But we can do tertiary, right? We can make sure that that illness doesn't become a disabling condition. And so it's an important program. My frustration is that we need at least 8 programs in Minnesota and we only have half of them. And if we knew we had kind of a wonder drug for some other illness, we would be putting all sorts of state money into it. This is a wonder drug in a sense, and we can't get the legislature to do more. Some other things that I'll just mention is we're now going to have an Office of Mental Health Parity within the Department of Commerce, which is great. Mental health parity has been a dream and not a reality. And the reason was because before, in order to, enforce the law, you had to have an individual make a complaint. Well, when you're in the middle of a crisis with your loved one and you find out that your insurance won't pay for something, you don't think, I'll call the Department of Commerce. Said no one ever, right? And so we can't depend on the individual to enforce the law. We have to depend on government to enforce the law. And so having this office will actually really help. We got some more money for mobile crisis services, which is also important. And then we have this program, it's a great thing online, Fast Tracker, that helps people connect to open services and appointments that are open and things like that. And buy your insurance because you need to make sure that you're using your in-network provider. The other thing I'll mention is we did get about a 3% rate increase for mental health services, which frankly isn't enough. We lost a lot of people working in the field during COVID and huge workforce shortages. We've had to close down hospital beds and residential beds because they can't attract people to work there because the pay is so low. There were a couple of things in the substance use disorder area. I'll just mention that one thing we're trying to do is some regulations around sober homes. Some are good, a lot are bad, and there's no regulations. And you're not a renter, so you have no rights. And so people are paying sometimes thousands of dollars a month to live in really crummy places, and there's nothing that they can do. And so we think there should be some regulation around it. They don't have to be licensed because they're not supposed to provide services, but there needs to be some protections for the people who are there. Also looking at using Medicaid for traditional healing in our correctional facilities, which is also great, and funding some more withdrawal management and safe recovery sites as well. Workforce. Got to get more people in the workforce. We learned from the Department of Health that we have thousands of people who finished graduate school and didn't go on and become licensed. We're like, well, there's an easy group to target, right? And one of the things we found as we started talking to people is that a lot of people said, I can't afford to pay for supervision. I need 4,000 hours of supervision. I can't afford to pay for it. The clinics can't afford to provide it for free. And so we have people who just never got through, right, the licensing. And then we also know that the licensing exams are actually not culturally informed. So the social work folks, they looked at their rates and they discovered that the people who fail the exam tend to be people who are Black, Indigenous, people of color, and men, because the test is geared towards white women. And it doesn't mean that someone else, if they don't pass the test, they're going to be a bad clinician. They were looking at the questions saying, well, maybe these aren't even good questions. So what we did is a couple things. One is that we increased the loan forgiveness program for mental health professionals. We also are going to train pediatricians in primary care alongside psychiatrists in a clinic so that they can increase their knowledge and maybe treat, kind of more simpler depression and anxiety instead of waiting for a psychiatrist for those. We are funding an additional psychiatry residency slot. And then we're actually funding BIPOC mental health professionals to become supervisors, because we also heard from BIPOC mental health students that they couldn't find a supervisor from their culture and race. So we said, well, let's do this. And we actually funded this 2 years ago, and 200 BIPOC mental health professionals are now supervisors, which means we have 400 students that can get supervision. And then also funding, giving money to community providers who take a lot of Medicaid, giving them money to provide the supervision for free, which attracts people to them who they don't pay as much, right, as a private clinic. And so it's kind of a win-win situation. So I bet you didn't even know that all that happened this last session, right? Because of what never gets in the news. We actually send out a weekly, every Sunday, you'll see it, legislative update and more than you ever wanted to know and what's happening on the federal and state level. And you can sign up through our website. So we didn't get everything passed. And one thing that I'm continuing to work on is called voluntary engagement. So, I've been with NAMI 22 years, and the hardest calls I get are from families who say, my loved one, I can see they're deteriorating, they're decompensating, whether they stop taking their medications or the medications stop working. I call the county and I say, can you please come out and help, because they won't seek treatment voluntarily. And the county says what? Until they're a danger to themselves or others, we can't do anything. And I just sit there and go, this doesn't make sense. We're waiting for someone to crash, basically. And we know they're going to. So when we changed the commitment law a couple of years ago, we added this thing called voluntary engagement. So a family could call the county and the county could send someone out. And it could be a peer specialist, which we think that would be the best, right? Because they've been there, done that. You send out the peer specialist and they look to see, well, do you have a psychiatrist? Do you have a therapist? Do you have insurance? Do you have housing? Hey, family, do you know about means restrictions to make sure that someone doesn't, have access to things that they could take their own life within their house? Don't know how to deal with voices? Let me talk to you about that, how you can kind of help your loved one. And it's not a one and done, which is what happens now. They don't come out once and say, no, I don't want treatment and never come back. They can come back every day for 90 days. And if I think about homeless outreach workers, they don't get someone into housing the first day, right? They create a relationship with that person. And then maybe a few weeks later, they convince the person to get into housing. We think we can do the same thing. Now, we asked for a lousy $250,000 and didn't get it, but they gave $500,000 to a psychedelic task force. Yeah. So we're going to come back, because if we really believe in early intervention, right, then that's what we have to do. We have to try to intervene early and do it in a way that it's not punitive, because commitment laws, why they're important, it doesn't mean that it's going to go on forever. And so if we can get people to engage in their own treatment, the chances of them staying with their treatment plan are even better. So it's one of those things that I don't think it would cost a lot of money, but we need to be able to test it out to see how it works. Respite care is really important. I actually was a respite care provider in Hennepin County for about 15 years. And the parents would come on Friday night and drop off their kid. And frankly, they looked like hell. They were exhausted. And so during that weekend, they got to do whatever they wanted to do, sleep in, be with their other kids, have a date with their spouse, do the laundry, whatever it is they needed to do. And they'd come back on Sunday and they looked rested. And so what we know is that when our batteries are drained, we can't deal with as much. And so what we want to do is recharge those batteries through respite care. And what we know is respite care prevents hospitalizations, right? Because you're not exhausted and you can deal with a lot more. Some other things are, there were some increases for the first biennium and not the second, which doesn't make any sense, because then you can't draw your folks back. We also think that non-emergency medical transportation needs a child mode, which it doesn't have. And I've had several calls this fall from families whose kids needed to go to day treatment, but there's no child mode. And so the NEMT providers won't take the kids because they don't know how to deal with it. We created a thing called Youth Shelter Linked. And so instead of youth shelters, hiring their own mental health professionals, doing the same thing like we did with School Linked, so that we can still connect kids to them. We wanted to try funding for what we're calling a first episode mood disorder. So basically for bipolar disorder, it's the same thing as schizophrenia, right? It can be a very disabling condition. So why wait till stage 4? Let's move it up and really do an intensive support for those young people as well. Creating a task force at DEED around mental health and employment. Try again. We also thought it might be good for community health workers who are really from diverse communities to get a special certificate in mental health, so that they actually have that knowledge and can work with those communities as well. And then funding jail social workers. And for this next session, we're also going to look at things like Medicaid for clubhouses or community support programs. We need to do a lot more around juvenile justice. And it's been an issue for many years. The juvenile justice system is the mental health system for BIPOC youth. And so we need to make sure that we're actually not sending them to juvenile justice. And if they do get into juvenile justice, we're actually providing intensive mental health treatment. And then we want to try to figure out how to do non-competitive grants. So the schooling grants, the mobile crisis grants, the first episode grants, those are all competitive. And so what the department keeps doing is rearranging the deck chairs on the Titanic. If you've got a program, you've got, Ramsey County's crisis team is getting, $1 million a year. Why would you take it away and give it to someone else? We need to create stability in those programs. So we're going to try to look at that too. It's a little tricky because of management and budget, but we're trying to figure out a way that we can do that so we're not rearranging those deck chairs. Now, I want to talk a little bit about seniors and mental health. There's kind of two groups, to be honest. So one, you have older adults who develop depression or anxiety in particular, right, as you age, and it is not a normal part of aging, I just want to say. But then we also have people with serious mental illnesses who get old. And so we have two distinct populations, and we need to treat them differently and have different resources available. So one of the things we see in terms of older adults is we see changes in mood, energy level, or appetite, not associated necessarily with a medical condition, right? You can start telling someone's starting to withdraw. We also see people having kind of flat, not positive emotions, sleeping too little or sleeping too much, difficulty concentrating, being on edge. One thing that we see, frankly, especially in men, when they get depressed, we always think of depression as rolling into a ball, but with men, they just get anger. They get angry. And so that is actually a symptom of depression in men. And then because our head is connected to the rest of our body, we see people getting headaches, stomach aches, things like that as well. And then misuse of alcohol and drugs. So people just drinking a whole lot more or, soon buying gummies to bring in here. Sadness, of course, is a huge issue. Engaging in high-risk activities. We don't see as much, although we do see some psychosis. Actually, this did happen to my dad. So he was hospitalized, and when you're in the hospital and as you get older, it's harder to adjust your sleep patterns. I don't know about you, but I sleep a lot lighter than I did. And so in the hospital, they're waking you up all the time. Well, so he's in the hospital and I flew in to visit him, and he's like, I don't know why the nurse put the baby on the windowsill. And of course it was a pillow, not a baby. And then he saw horses out the window. Well, none of that was true, but it was because of that lack of sleep and that interruption that actually caused those kind of psychotic symptoms, which is also something to look at in the future. So one of the things we know is that about 20% of older adults do experience depression and anxiety. Some of it is actually related to other healthcare issues, right? And the rate of older adults with depressive symptoms tends to increase with age. And mostly it is treatable. It's a little harder sometimes in terms of medications and therapy, but it is definitely treatable. We do know that, as we age, metabolism changes and things like that. And so, and alcohol, of course, can have a huge impact because alcohol is a depressant. And, it's kind of like, well, there were lots of jokes during COVID about alcohol, right? Like people are saying, well, it's, it's 5 o'clock somewhere, things like that. And so there was a lot more drinking during COVID. Liquor sales actually was the one thing, even beat toilet paper sales, right? It was just way up. And then we also know older adults are less likely to seek treatment, which I think is actually will start changing as baby boomers get older too, because we don't see mental illness as that big of a deal compared to other healthcare issues. And so I think we'll see that change. Certainly my mother's generation, she was in her 90s, right? She was not going to seek mental health treatment, but I think we're seeing some of that change, which is a good thing. And then I just want to mention loneliness. So the Surgeon General had his big report this last spring and talking about the epidemic of loneliness. Now, COVID certainly had a lot to do with that, right? Because we couldn't really see people and we couldn't visit and all those kinds of things. My kids lived, out of state. And so it's like, well, okay, we're going to do a lot of Zoom calls, which are nice, but it's not quite the same thing. FaceTime is not the same thing as seeing someone in person. It's better than nothing, but it's not the same thing. And so what we also see is that as people get older, they lose some of their circle, right? So people lose their spouses, they die. And as someone who's, a widow for 2 years, I mean, it is hard coming home at night and having no one else to talk to, right? So it is lonelier, frankly, in some ways when you're used to living with someone. Some of your friends have died, right? Transportation might be difficult. So you tend to start isolating more at the older that you get. And then men were more likely actually than women to report not receiving kind of those community supports. And so I think it is important, especially for men, to have those things. My husband actually had well, they called it beer night, but when you meet at 5 o'clock, I called it beer afternoon. But at least he was getting together with some other men, right? And having kind of a group of friends, which we thought was important. So suicide, I want to say, when we looked at where did it increase? Because suicide increased this last year. It's older men over 85, and frankly, with guns. So more women attempt, but more men complete suicide because they tend to use more lethal methods. And so it's also important that we get guns out of the house when we are worried about somebody's mental health. So adults in nursing homes, we know that this has been a problem, right? Because for many years, they just relied on medications to calm someone down. And then that led to other problems like people falling out of bed and all those kinds of things. We don't have many geriatric psychiatrists or psychologists, and it's different, right? Because you have healthcare conditions that you need to consider, mobility issues, all sorts of things like that. We also know that if you have a serious mental illness and you're not 80 years old and you're placed in a nursing home, you tend to get placed in crappy nursing homes. And then we also know that people who've been committed, especially if they were committed mentally ill and dangerous from St. Peter, are often refused nursing home care, even though that's what they need. We had a person who was 50 years old, had come out of St. Peter, had been there 15 years, hadn't done anything in those 15 years, was really doing well, developed cancer, really needed a nursing home to take care of his healthcare issues. And there wasn't one nursing home in the state of Minnesota that would take him because of that previous commitment, which is also really too bad. And the other thing to think about is that we know that there's disparities in terms of who's committed as being mentally ill and dangerous, and it's Black men. Whether they're viewed as more scary by the judges or prosecutors, I don't know, but it's disproportionate. And when you look at exactly what they did, they shouldn't have been. The other thing that we know is, so about, close to 5% of adults over age 65 have a serious mental illness. People with serious mental illnesses die 25 years earlier than their peers, and it's not due to suicide, it's due to healthcare issues. Very few people with a serious mental illness actually have a primary care physician. And yet some of the drugs, lead to obesity, they have high smoking rates, all of those kinds of things, which is a problem. And one of the reasons that it's harder to get people with mental illnesses into a nursing home is because we did it too much before. So when the institutions closed, and I just want to say I would have brought the pictures, there was a reason they closed and they needed to close. The problem was everyone likes to blame President Reagan for closing the institutions. It's not true. It was President Kennedy who closed the institutions. It was President Reagan who destroyed the community system and took away all the funds that were going to go to community mental health centers and made them block grants to the states with no strings attached. So blame Reagan for that part. But that made it hard then. And so what they're trying to make sure of is that you're doing a screening to make sure that that person could maybe go somewhere else other than a nursing home. And now it's made it so hard that we can't get people into the nursing homes who really need to be there, who have a serious mental illnesses. The other thing that we're seeing, of course, we have people in the, boarding in the emergency rooms, but also sitting in a hospital bed when they don't need to be there. And that it kind of creates a flow issue, right? Like we always say, yes, we need more beds, psych beds. There's no question about it, but it's also a flow issue because you have people who are in those beds who could be somewhere else. And then you have people in the emergency room who could go in there. So it really, in some ways, is just a flow issue and not necessarily saying that we need lots more beds. There was a study that was done to see why, what's happening with those. And so when you look on here, the numbers are pretty amazing. So 6,000 of those days were potentially avoidable. So the person could have been discharged. So that's 1 in 5 patient days. And a nursing home bed was not available just for 2% of that population. But still 2% is 2%. And when they looked at some of the reasons, some of it was due to the commitment laws. Some of it was due was waiting for what we call a caddy waiver. So we get more community supports. So it was kind of really kind of spread out. It wasn't like there was like one thing, right? There were just lots of little things that led to those delay in discharging people out of the hospital. So when we look at, so what can we do about all of this? One thing I think is, again, looking at the workforce issues is, if people are studying geriatrics, why don't we do a loan forgiveness program for them so that we can get more people into that field, you know? Also looking at requiring training. So we've managed to get, you know, teachers. We're actually the first state in the country to require teachers to have continuing education on the early warning signs of mental illness in kids. We require police now to have very specific types of training related to mental illness and de-escalation. So maybe there's a way to start requiring people in nursing homes and who work with older adults some training around mental health as well, so that they know what to do. Also looking at, you know, expanding educational programs for training, and training people on how to work on integrated teams, which people usually aren't, they're not really good at that, right? We're not good at crossing those borders, but that will really help because you're sharing that knowledge. We're seeing a lot of the big healthcare systems like Alina and Fairview putting, for example, mental health professionals within a primary care clinic. So someone can just walk down the hall and get that maybe additional support instead of having to create another appointment, you know, somewhere else. Medicare. So I know everyone, you know, loves Medicare, but I don't, because it doesn't pay for mental health. Only this last year did they finally expand Medicare to pay for all types of mental health professionals. Prior to this year, they didn't pay for marriage and family therapists or licensed professional clinical counselors. Those two types of mental health professionals work where? Rural Minnesota and in BIPOC communities. And Medicare didn't cover them until this year. Medicare doesn't cover mental health residential treatment. Mental health care doesn't cover crisis services. So there's a lot that Medicare doesn't cover, which is particularly painful. So we need to have mental health parity actually apply to Medicare so we can make sure that people can actually get the services that they need. Why they started paying for telehealth, they don't pay for telephonic care, but they also have these kind of on-site requirements, and that you have to have an in-person visit before you can do telehealth. Just really problematic in rural Minnesota, right? And I think, you know, prior to COVID, hardly anyone did telehealth, right? Or Zoom. Like Zoom was a word we never even knew of, right? Prior to COVID. Well, now telehealth is really, you know, we all get that, right? And so it's kind of silly to do that. So they need to do that. And what they've done several studies lately to find that Medicare Advantage in terms of network adequacy is not great at all. And so that's something else that needs to be changed. Staff training, we've kind of talked about that. Making sure that we're funding beyond like medication management and collaborative care, expanding that to Medicaid, I think will also help in terms of being able to connect people across those things. So to kind of wrap it up, so our mental health system isn't broken. It was never built. We relied on state and county grants. During every single recession, you can look to see how much Black grants are cut. That's what's cut, right? Because you don't have a clear constituency to fight for it. So they've been cut. When Reagan made those Black grants, actually in Minnesota, there was a huge expose by Jerry Joseph, who just recently passed away. And she did a huge, she also did a huge story called Bedlam that actually talked about the poor conditions in the state hospitals. But that money came to Minnesota and nobody knew where it went. It didn't go to mental health. And so those monies were misspent. And then of course, Medicaid it has discriminatory policies. It's called the IMD exclusion, Institute for Mental Disease, which means that Medicaid can't be used in any facility of more than 16 beds where more than half the people are being treated for a mental illness or a substance use disorder. So Anoka Regional Treatment Center with 100 beds can't use Medicaid. That's all state funding. All of our residential facilities for adults in Minnesota are 16 beds so that we can use Medicaid. Now they just came up with that number. There's no research behind, you know, if it's 17 beds, it's an institution, right? They just came up with that number out of the air. But that's a problem. And even with our waivers, which is kind of the community-based services, it's different for kids with mental illness than kids with other developmental disabilities. If you have a developmental disability as a child and you need to be kind of placed outside your home for care, all you need is kind of residential level. But if you're a kid with a mental illness, you need hospital level. So we have far fewer families accessing services under Medicaid who are middle income, for example, than for kids with disabilities. And it's because of this discriminatory policy. Medicare actually has a lifetime limit on the number of inpatient psychiatric bed days you can have. And then, of course, if anyone thinks private insurance is covering what they need to, we need to talk. So in moving forward, we want to build on what we know works, because we know a lot of things that work. Schooling works, first episode works, crisis services work. We know what works. And actually the best report and study I ever saw said that we should have, every hospital should have a community, should have a psychiatric unit. We should have a mental health center for every 50,000 people. We should have crisis services. We should have services for kids in the school, and we should address the shortage of child psychiatrists. You want to know whose report that was? Eisenhower. I love doing that to people because it's like, oh my gosh, we have known forever, right, what we needed to do to build our mental health system. We want to make sure we have statewide access. I don't care where you're living in the state of Minnesota, especially with telehealth, you should be able to access care. We need to make sure that we're not starving our providers, right? That we're paying them so little that they can't do the things that they need to do and they can't hire people. And then we definitely need to expand our workforce, including the diversity of our workforce. This is one of my favorite quotes: we make the road by walking. And so, we have great ideas about where we need to be in terms of both, how we support older adults, but also people with mental illnesses. And it's not going to happen if we don't take those first steps. Here's our website, NAMIMN.org. We also encourage you to sign up for your legislators' updates, which you can go to their sites to sign up for that, because then you can really find out what's happening. And then the true meaning of life is to plant trees under whose shade you do not expect to sit. And for me, that's really about, like, when my family members, we had to deal with the lack of mental health parity and paid a lot of money out of pocket for the care. And so I'm very strong, right, and a strong advocate for mental health parity. Now, it's not going to help me anymore, but I don't want anyone to go through what I went through. And so I think we all have to think about, doesn't matter if it doesn't impact me personally, I want the system to be better. And that's how we really create change. And then, of course, Margaret Mead's quote, because all these years that I've been advocating at the legislature since '81, it's not about money. It really isn't. It's about people making their voices heard. So I have a few minutes. If there's any quick questions, I have a meeting that starts at 11:30 back at my office, but it's close.
Thank you, Sue. Thank you very much. Quickly, are there a couple of questions? Must be questions. No questions? Thank you, Sally.
It's not exactly a question, it's a comment. I think one of the biggest problems that unless you've come in touch with mental illness, people simply have no idea what you're talking about. So it's one of the reasons why you don't get no support, because people don't get it.
It's true. It's changing. And I think COVID helped, because during COVID, most people for a couple of days at least felt anxious or depressed. And so, I mean, we've seen a much greater conversation since COVID. If we can look for any silver lining out of COVID, that would be it.
Betty?
I barely remember the day of the community mental health center grants that at that point it was called ADAMHA, Alcohol, Drug Abuse and Mental Health Administration. But the time I started working there, they were phasing them out. And they just had to make sure every year that those agencies had continued because they'd gotten the grant. They had to go for so many years. Whatever happened to, I mean, who did that?
So that was Reagan. So Nixon did it first, because Nixon actually said, I'm not going to send any of that money out. And the American Psychiatric Association sued the government. So then he had to release them. But then he worked with Congress to say, we're not going to fund any new ones, only the existing ones. And then Reagan took that money and put it into a block grant with no strings to the states. That's what happened to it. Oh, I think so. And actually, we're going back to it now. So now we have these things called certified community behavioral health centers to be one-stop shops, which is exactly what President Kennedy wanted. So they're going back to it now. They're funding them in a different way. It's more oh, what's the word? It's forward thinking payment instead of based on your expenses, so that they were able to hire a whole lot more people to meet the needs. So it was a demonstration project. It's now becoming more permanent. Everyone in Congress seems to like it. So providing better Medicaid funding is really the way forward.
Marty.
So just a ruthless plug to folks here at the village. We had Vale's Place come about a month ago. They're trying to get zoning changes so that they can open a center here in Ramsey County. So let's be looking at ways we as a community can do more advocacy and partner more with NAMI. My big question would be, in terms of children, top news story again today is 50% increases in mental illness with our children in schools. What could we be doing in terms of advocacy, especially with children, or maybe it's not advocacy? What can we do to support the children? Because it just seems a really big crisis right now.
So we need adults to be advocating for them. You know, when your kid is younger, and one of my children had a suicide attempt at 13, you know, you're in crisis. You're not going to call a legislator, right? And so we need to be calling for them, right? And advocating for them. So I would definitely sign up for our legislative updates, because we're going to tell you when those children's bills are up. But also providing that extra support in the schools, right? I mean, I don't care what people say, they're still shorthanded in the schools right now, especially since so many kids didn't make it out of COVID doing very well. They need extra people, frankly, to help in terms of whether it's reading to little kids, you know, doing meditation, mindfulness training with little kids. You know, we really push the Calm app or Headspace. I mean, me doing yoga for 30 minutes ain't never going to happen, but I can do the 2-minute meditation on Calm, which can really help. And, you know, doing the deep breathing, all those kinds of things, helping kids learn those skills is really helpful for them, and will help them be more resilient in the future as well.
All right, Sue, I want to thank you. It's an amazing amount of information, right? There's a lot going on. I would also say that within our building here, Mary Ellen Kennedy, who's on our Justice Seekers group, is going to check in the library and see if we would have some publications, some books to highlight for people if they want to do some additional reading. Sue brought a variety of these pamphlets with the contact information. I strongly encourage you to take one and sign up, and stay tuned, because I imagine our Justice Seekers, this probably isn't our last effort at trying to do something in this particular area too. So thank you very much for today and for all your years of advocacy. Thanks.
And just in case you want to rewatch the presentation and take in all the facts that were there, it is on the CSJ YouTube channel, so you can go there and watch the video of this or share it with folks who weren't able to attend. And then for our Justice Wednesdays, not this coming Wednesday, but the following Wednesday, November the 8th, we are hoping to have Sarah Illegal from Project Home. So the family homeless shelter that's right next door in the Provincial House. We're hoping to have Sarah Legal come on the morning of Wednesday the 8th to share updates about their work there as well. So watch for information on that. So if you go to, just type in a Google search, just type in YouTube and type in CSJ St. Paul, and it should be right on that page there. We can also, through the Justice Seekers, try and send out that link, but just go to YouTube on your browser and type in CSJ St. Paul or St. Paul. Alrighty, well, hopefully see you again in a couple of weeks for Project Home, and there's flyers there about NAMI on the table too.